Well, thank you very much, Richard. It's a great honor for me to be here with you this afternoon. I just got off the plane and then the car and landed and walked over, so I'm a little bit on the warm side, so please excuse me. These are my disclosures. I do get royalties from a couple of different products that I helped to design, and I own stocks in some companies that I purchased, and then I have some other things that I am affiliated with. I'm going to tell you the story of two necks to start out with. Two patients that I treated. This is a patient with neurofibromatosis who has just simple radiculopathy and neck pain. And otherwise, unbelievably, despite this terrible looking neck and the fact that the spinal cord seems very stretched, this patient has no myelopathy, just has a radiculopathy. And we thought about how to treat this, and this was about maybe close to 20 years ago that I treated this individual, and I decided, let's just do the very simplest thing. Don't even bother correcting the deformity. Just decompress him and fuse him in situ. And he did spectacularly. The x-ray looks terrible. I didn't do anything about the deformity. And the patient says, I feel great. The radiculopathy resolved. This was a patient sent to me by some surgeons from the University of Michigan. He's had radiation treatment. And patients who've had radiation for Hodgkin's lymphoma will, about 20 years later, develop myonecrosis and fatty degeneration of their neck and often develop a dropped head syndrome. And they will often end up with a kyphosis that's fixed due to a fusion. And I was doing a surgical demonstration about 15 years ago, and I did this procedure, and I was showing all the different ways of fixing the anterior spine using cages, expandable cages, all of this. And I got the cervical spine very lordotic, but as you can see, it's not a very good correction. And I'll show you in a little bit why it's such a bad job. About 5 or 6 months postoperatively, he falls and fractures his upper thoracic spine, and he had to be extended down even further. But even after this, he has some base of the neck and upper thoracic pain. So this is the tale of the two necks, two patients that I treated. One whose x-ray, both of whose x-rays actually look terrible, but one who has a neck, the neck number one, which is not in pain, and number two, the patient is not happy with the results. And let's see why that happens. Because I would tell you 15 years ago, I didn't really understand why neck number two was not happy and why neck number one was happy. And I want to share with you some of the insight that have been gleaned over the last 10 to 15 years about deformity and its impact on our patients. So when you assess global spinal alignment, you have to understand that there's an interplay between the cervical, thoracic, and the lumbar spines, that one affects the other. And you cannot, even though I only do cervical spine, I still have to pay attention to the alignment in the thoracic and the lumbar spines. And we're going to share with you some of the newer concepts that most of you probably have already known that we use now to assess how good a job we have done when we correct cervical spines. This patient was sent to me after her surgeon had done 2 or 3 different operations and left her in a kyphoscoliotic position in her neck. And you can see she is hyperextending her lumbar spine in order to look straight ahead. And she's complaining about low back pain as a result of the fact that she cannot look with her head held up high. So she compensates by hyperextending her lumbar spine. And you can see after we fix her cervical spine alignment, she says the back pain has disappeared because she no longer needs to hyperextend in order to gaze straight ahead. So we understand that the neck affects the back. And one of the few ways that you can surgically treat low back pain with a high yield is to fix a kyphotic deformity of the cervical spine, because if you do, they can stand up straight. But the back also affects the neck. In this individual who had had a thoracic down to the sacral fusion by my partner Larry Lenke, she comes to me with severe base of the neck and cervical spine pain and difficulty holding her head up. And if you take a look The reason that she has a problem in her cervical spine is that she has a very kyphotic upper thoracic spine. She's actually hyperlordosing her cervical spine. Her lordosis in the cervical spine is perfect. It's just that the slope of the upper thoracic spine is so vertical that the only way that she can look ahead is by hyperlordosing her cervical spine. And when you fix her, as I did here, not by really doing anything to the thoracic spine, but just doing an osteotomy here, and then fixing her up to C2 so that she can hold her head up high, that results in decreased pain and improvement in her function. So what we understand is the T1 slope. The slope of the T1, the more vertical this is, the more lordotic the cervical spine must be in order to look straight ahead. And you want to have a T1 slope that is relatively horizontal. So if you take a look at this patient who has a very, very vertical T1 slope, the only way that they can look straight ahead is by hyperlordosing their cervical spine. This loads the facet joints in the back, and the patients complain bitterly about neck pain. Their neck fatigues, and eventually they start holding their neck lower and lower and lower. And you can see in this individual, they're hyperlordosing their cervical spine and hyperlordosing their lumbar spine to compensate for the severe kyphosis she has in the mid to upper thoracic spine. What we understand now is that the patients want to maintain a horizontal gaze. And if the spine is balanced, that's easy. But if the patient has a problem in any part of the spine, they're going to compensate with whatever moves in order to be able to look straight ahead. We only used to pay attention to cervical lordosis when we operated on the cervical spine, and we said if the cervical spine is in lordosis, then you don't have to worry because everything is good. And if you can see another patient that I operated on about 20 years ago as a visiting professor at Albert Einstein University, and they brought in a homeless person with a dropped head syndrome, malnourished, and we fixed him here. And again, this was a terrible job. The cervical spine is in lordosis, but what you can see here is that I've left the T1 slope a little too vertical. And as we will see, it is like the Leaning Tower of Pisa effect. Unless you build a building straight up and down, over time, it's going to collapse. And you can see that the head is way forward of the gravity line. And so this is doomed to failure, and indeed it did. And we wrote this case up as what not to do in the cervical spine. And the way you assess that is by looking at the C2, the center of the C2 vertebra, to the posterior superior corner of C7. The C2-C7 sagittal vertical axis tells us how much that patient is leaning forward. So you can see in this patient the C2-C7 sagittal vertical axis on the day after the operation was terrible. You can see that I did a terrible job in this case and that this patient was doomed to failure. And in fact, there is a very good correlation now that we know that the greater your C2-C7 sagittal vertical axis, the greater the degree of neck pain you have. So there is a clear correlation. If you leave a person with their head way forward of their center of gravity, they are going to have to utilize a lot of their cervical muscle power in order to hold their head up. And that's going to lead to fatigue and pain. So we go back to the tale of the two necks. And we say, why did patient number 1 do so well while patient number 2 did not do so well? And it's obvious now, because we see that the sagittal vertical axis here falls right over. Even though the cervical spine looks terrible, the overall alignment from the center of gravity of the skull falls right through and all the way down into the hips. In this one, it falls way forward. And that's why I failed with this patient and I succeeded with this one. Now, cervical deformity correction, what do you do when you have these terrible deformities, and how do you avoid the kinds of mistakes that I made early in my career? Because these are often very complex cases. So you have to look for the very simplest approach, and you have to understand that if you do a poor correction like I did with those two patients, you will end up with often distal failure. Now, this is a block of Carrara marble. It's a fantastic piece of stone that has been formed over millions and millions of years by tremendous pressures, by the pressure and heat of the earth. A man named Agostino de Duccio in 1464 was commissioned to make a wonderful statue of David in the story of David and Goliath. And he embarked on this. This piece of marble took a long time to be quarried and brought down to Florence, and he started working on it. And after a few years, he realized he was way in over his head. This was not something he could accomplish. So it sat there for the next 37 years until Michelangelo took the same piece of marble and started chipping away and chipping away. And what he said was that I saw the angel in the marble and carved until I set him free. And I will tell you, all of us who do deformity surgery, all of us can say that at one time or another, we have been Agostino de Duccio. And most of us, we strive to become Michelangelos, to set the angel within that deformed patient's spine free. But most of us don't get there most of the time because we have to understand all the principles. And just the way a sculpture cannot make a single mistake, imagine you're making David and you get to the last part, you're carving the hand, you hit the thing a little too hard and the entire arm falls off. What do you do then? And it's the same thing. There's very little room for error when you're treating complex deformities. The first thing you have to decide when you see somebody with a deformity is, are they fixed or are they flexible? One way that I do it is I have my patient lay down as I talk to them. I say, lie down over here, and then I look at their x-rays, and I see where their head is. If their head, after 5, 10, 15 minutes, is still up in the air, I know that they have a very fixed deformity. And of course, I follow that up with the gold standard, which is a CAT scan. The CAT scan tells me what levels are fused. If it's fused, traction will not help. No matter how long you keep that patient in a position of dependency, their neck will always stay in that fixed position. The second thing that I have to decide is how far down do I need to correct this person? Can I do it with just a cervical approach, or do I need a cervical thoracic correction? So this individual, you can see, and one easy way to tell in clinic is if you drop a line from the tragus of the ear and it falls pretty well, this person is well aligned, the line falls behind the manubrium. If it falls behind the manubrium, then any deformity they have is a cervical deformity, and it can be corrected in any way you want, anteriorly, posteriorly, front, back, whatever you want. So again, a line drawn from the basion, drop down. If it falls behind the manubrial notch, you know that this is a problem that's not too bad. Another way to look at it is to look at the T1 slope, and if the T1 slope is horizontal, you know that it's not a problem with the thoracic spine. So when you have a patient like this, you can do anything you want. You can do the front, you can do the back, you can do a combination of the two. Now, if that basion or C2 tip line, vertical line drop down, falls in front of the manubrium, that means that that patient has a very vertical T1 slope, and the problem is more likely to be in the upper thoracic spine. So if you don't recognize that, and I didn't in those two examples that I told you that I did years ago, I fixed the cervical spine, and this cervical spine is in neutral alignment. If you fix it in neutral alignment, this patient is not going to be any better because the deformity is not in the cervical spine, it's in the thoracic spine. Then the next thing you have to do is decide, do you want to do a posterior pedicle subtraction osteotomy or a Smith-Peterson osteotomy? Do you want to do a front-back front or a back-front-back? Or can you get by with just an anterior osteotomy or an anterior-posterior procedure? This is a patient with ankylosing spondylitis that I treated years ago, and you can see the positioning. I do them with the patient asleep and with spinal cord monitoring. We did a pedicle subtraction osteotomy, went to the skull and all the way into the thoracic spine, and we got an excellent correction of his deformity. And I also did a pedicle subtraction osteotomy for this individual who had had multiple anterior and posterior operations all the way up to the skull, where the plate had pulled off the skull, and she had a kyphoscoliotic deformity. And I fixed her all the way up to the skull. Now, when you go all the way up to the skull, and you go all the way into the upper thoracic spine, you cannot put these individuals in a head-up position because then they can't see their feet when they're going down the stairs. They can't see the front of their body. You have to keep their head tilted just a little bit forward. So in this case, a slightly increased sagittal vertical axis is the desired angulation as opposed to keeping their head in a very vertical position. This is a patient who had had a laminectomy for an astrocytoma at a young age. And if you get a laminectomy at a young age and you don't reapproximate the muscles carefully, 100% of children will go on to kyphosis. That's because the major extensor muscle of the neck, the semispinalis cervicis, originates out of T1 through T5 and inserts into C2 to C5. And if you take away the C2, C3, C4, and C5, there's no muscle to hold their head up. They sag, and she eventually went on to a solid fusion. But she has a very patulous dura here. And you can see that going in the back, it would not be easy to get fixation in the back. And she's fused in the front. So we did an operation from the front doing osteotomies. And again, this isn't a perfect correction, but her sagittal vertical axis is well aligned. And she's quite happy with the results of the surgery. And it was much easier than doing a front-back or a back-front operation in a patient like this. This is one of the first anterior osteotomies I performed. A patient, again, who'd had multiple operations before being sent to me, infections and a number of different procedures with a terrible deformity and very unhappy with their life. And we did an anterior osteotomy first, and you can see with just an anterior, despite the fact that he's solidly fused in the back, you can get quite a bit of correction with an anterior osteotomy. And then we finished him off with the posterior osteotomy and posterior correction to get his final alignment. Another patient with a kyphoscoliotic deformity, after having had a scoliosis operation, she was in this position for years with severe facet fusions and myelopathy. And the key here is to first find the uncinate. So the head is here, the foot is here, this is the right side, and there's a Penfield 2 lateral to the uncinate here, a Penfield 4 lateral to the uncinate, and this is the disc space. So we got a Penfield 2 on one side, 4 on the other, and we're going to cut through this fusion mass right here. So we have the patients positioned in this position. We have a pillow underneath the head, and we go down, and just like an anterocervical discectomy and fusion, you burr all the way down until you hit the posterior longitudinal ligament. And then using a set of Caspar distractor pins, we then, through the sheets, after anesthesia takes out the pillow, we push down on the head, and that breaks the posterior fusion mass through the facet joints. It's a very safe procedure because once you have done a good foraminotomy and a central decompression, when you push it down, the foramen opens up, so the nerve becomes decompressed by using this maneuver. After you've done that, you put an underside graft and you put a little block to it, and this is what it looks like intraoperatively. So there's a Penfield 2 lateral to the uncinate, and we're cutting here. The head's here, the foot is here, and we have 2 Caspar distractor pins here, and after cutting through, we will distract, so you can see before the distraction and after the distraction. And again, we're pushing down on the head simultaneously. Then we go in the back and using spinous process wires and cables to pull it together, because if you just drop the rod down, the rod does not have the ability to hyperlordose the spine as easily. We place the rod, and so this is how we position the patient. And even with them kyphotic, you can approach the neck. If they're kyphoscoliotic, you have access on this, in this patient, on the left side. This is what it looks like positioned, and after the anterior, this is what she looks like. And then we position her posteriorly like this, and at 1 year post-op, we use a variety of standalone cages for the front, and this is the pre-op and 1 year post-op images of her cervical spine. Another patient with a similar kyphoscoliosis that we treated at about 2 months post-op. Even patients who have posterior instrumentation in can be managed with just an anterior posterior osteotomy, because the instrumentation will bend. It will bend enough that you can actually still go in from the front, take care of the front first, and then go in the back and fix the rest of it to get from here to here and from here to here. So we looked at our results with SPOs and PSO versus anterior osteotomies. And we found that if we did a Smith-Peterson osteotomy, the average time was about 3 hours and 50 minutes with 230 cc's of blood loss. Pedicle subtraction osteotomies were about 5 hours, and the blood loss was the highest. If we did an anterior osteotomy with just posterior stabilization, the total time was 3 hours and 26 minutes, and blood loss was the least. If we did an anterior osteotomy and a Smith-Peterson osteotomy, then it led to about the same times as a PSO, but less than half the blood loss of a PSO. And we published this in Spine in 2015. I'll leave you with one last case. This was a patient who had cerebral palsy. And he couldn't feed himself because he has severe stenosis up at the craniocervical junction, and he's kyphoscoliotic. He has congestive heart failure. We did a C1 laminectomy and a C1-2 and a C7 osteotomy. It didn't take us very long. I had a wonderful assistant with me who's now a neurosurgeon, spine surgeon at the Mayo Clinic. But he did fine until about 6 weeks post-op when he developed congestive heart failure, and he passed away. And probably he passed away as a result of having had, even that small operation was probably a little too much for that person. And Voltaire said, "The doctors are men who prescribe medicines of which they know little to cure diseases of which they know less, and human beings of whom they know nothing." And the fact is, you can say that we were guilty of treating the deformity, not looking at the entire patient, understanding that maybe all we needed to do was just decompress them at the craniocervical junction. That would have been a 25-minute operation as opposed to a 2-hour operation, and maybe that would have made him better. So I go back to Michelangelo's David. The marble, the Carrara marble, was quarried in northern Italy. And this marble, it is said, is actually not a good piece of marble to create a sculpture with because it has microscopic pores in it. And that makes the marble weak. And now they show that Michelangelo, the center of gravity here is off. And so his ankles are seeing tremendous stresses. And they say with the next bad earthquake that this whole thing could come crashing down because when you take a look at the stresses, this is not a good position to be in. So this sculptor, maybe it was Agostino starting out sculpting the legs, or maybe it was Michelangelo. But when you start out with poor marble, and then you make the first mistake, no matter how much of a genius you are at doing the other thing, if you start out with bad marble, eventually you are doomed to failure. And Harvey Cushing told us that a physician is obligated to consider more than a diseased organ, more even than the whole man. He must view the man in his world. And I would say that the analogy of the sculptor using poor marble and poor technique is a perfect analogy for us surgeons because we surgeons too are artists. We take what is deformed and we try to make it straight. But too often, we operate on people without realizing that they cannot take such a big operation. Or we do it, but we don't understand that they don't have the social background at home to support them. And so as surgeons, we have to pay attention not just to the deformity. We have to pay attention not just to the deformity in the cervical spine, but we have to look at the global alignment. And then we have to understand what that man's medical environment is like. And then we have to understand how much support they have at home, what their nutrition is like, because all of those factor into whether you will get a successful result from surgery or not. And so with that, final thought, merci beaucoup.